fluid compartment and the microcirculation, which we started. So we were done with the initial part where we talked about what is osmosis and how how the flow of the fluid is determined via the osmotic pressure, what is osmolarity, what is osmolarity. Now let's talk about the microcirculation. So you have to know one thing. So there are two types of the forces that will determine the flow of the fluid or the water across your capillaries or across your blood vessels. You know, you have the blood vessels here, and the blood containing the blood cells as well as the plasma is flowing here. So every time there is some exchange or the movement of the fluid across these capillaries or the vessels, and this is determined by two types of the forces. First, we have the hydrostatic force. Hydrostatic force is just the pressure of the water. Okay? The water which is flowing here has its own pressure, that is known as the hydrostatic force. Second, we have the osmotic or the oncotic force, which is actually due to the solutes that will be present here. So solutes can be present here or solute can be present outside. These solutes are responsible for a force that is known as the oncotic or the osmotic force. These solutes that cannot cross the membrane, they are responsible for this force as well as the movement of this fluid. So we have the this force. It is present both outside the capillary as well as the inside capillary, because water is fluid outside in the interstitium. Water is also fluid within the capillary. So here we have hydrostatic pressure. Okay, that is that is here of the water. Here we have solute also, that will be the oncotic pressure represented by the pi. Similarly, in the capillaries, inside the capillaries, you have the oncotic pressure and you have the hydrostatic pressure because of the fluid and because of the solutes here. So let's talk about what is filtration, what is absorption. Filtration is just the fluid that will move outside the from the plasma or from the capillaries into the interstitium. That is a filtration. Absorption is just movement of the fluid from outside into the plasma or into the capillaries or the blood vessels. So this is the filtration and the absorption. So in this picture here, we'll talk about the osmotic pressure that is represented by P, and pi is also known as the osmotic or the oncotic pressure that is due to the solutes, and mainly it's the proteins. Now let's talk about what are the forces of the filtration and what is the forces of the absorption. One of the important forces of the filtration is the hydrostatic pressure or the pressure of the blood or the fluid within the capillaries. So this here, PC capillaries, hydrostatic pressure, it will be responsible for the filtration. It's moving the fluid out, and it is directly related. The more the amount of the blood flow within the blood vessel or the blood the blood volume, the more is the hydrostatic pressure, right? Because it's the pressure of the water. Then we have the oncotic pressure within the interstitium. This oncotic pressure, it is determined how much is the proteins or how much is the solute present in the interstitium. Okay. So normally what happens is that there is a small number of the proteins that is leaking from your blood vessels into the interstitium. And these proteins which are leaking from these vessels into the interstitium, they are usually removed by the lymphatics. So that's why oncotic pressure of the interstitium is very low. So it's not a major factor responsible for the filtration. Then what are the forces of the absorption? First one is the oncotic pressure of the plasma. Okay, that is which is present here inside this oncotic pressure of the plasma. This oncotic pressure is due to the solutes that is present on the plasma, and these solutes cannot move from the capillary membrane into the interstitium like the plasma proteins. And the most important one here is the albumin. It's the biggest contributor to this oncotic pressure of the plasma. Then we have the hydrostatic pressure. Water is also present in the interstitium outside. This hydrostatic pressure, it is the pressure of the interstitium. That's also an important force of the absorption. In most of the cases, it's actually negative or zero. And it's not a very significant force that will affect the filtration and the reabsorption. But if there is edema, what is edema? Edema is the excessive fluid that is present in the interstitial space. So if there is excessive fluid in the interstitial space, there will be increased hydrostatic pressure within the interstitial space, and that can actually increase the hydrostatic pressure, and then the hydrostatic pressure of the interstitium can become a significant force responsible for the absorption. Also, at that time, it can also responsible for the glomerular filtration in the kidney. Now let's talk about the Starling force, Starling equation. Starling equation actually talks about these four forces, which we said, like the hydrostatic pressure of the capillary, oncotic pressure of the interstitium, then oncotic pressure of the plasma, and the hydrostatic pressure of the interstitium. So all of these forces are together referred to as the Starling forces. We call them Starling forces. And using the Starling forces or the Starling equation, we can calculate the amount of the fluid exchange across any capillary. So the fluid movement, that is the QF, it is determined by the KF, that is the filtration coefficient, plus the forces of filtration minus the forces of absorption. So that will determine the net amount of the fluid movement. The forces of filtration is the hydrostatic pressure within the capillary and the oncotic pressure within the interstitium. Then minus the forces of the absorption, that is the oncotic pressure of the oncotic pressure of the capillary or the plasma and the oncotic pressure of the interstitium. And there is this filtration coefficient. Now this filtration coefficient depends upon a lots of factor, okay, but the most important one is the permeability of the capillary or the wall. That is very important. And there are lots of things that will increase the permeability of the capillaries, that will actually increase the fluid to move out from the capillaries into the interstitium. So if QF is equal to positive, it means there is net filtration of the fluid outside the capillaries into the interstitium. If it is negative, then there is a net absorption. So they're talking about here, like in the kidney, like the renal glomerulus, the filtration part is the most important. So the filtration occur along the entire length of the glomerulus or the capillaries. In the intestinal mucosa, absorption occur entire the whole length, because absorption is the main process here. So these are the different things which we need to talk about, this about the Starling forces or the Starling equation. Now let's talk about the lymphatic fluid. The lymphatics, they play a very important role, because they are removing the fluid as well as the proteins from your interstitial space. So they are very important because they will maintain a low interstitial fluid volume as well as the protein content. So as much as there is increased pressure of the interstitial fluid, there will be increased lymphatic flow, because that will be removing that fluid from there. Okay. So if there is an increase in the pressure, that will promote the fluid movement out of the interstitium via the lymphatics. The lymphatic will remove that extra fluid. Again, lymphatics also removes the proteins from your interstitium. Okay. And then it will empty it within the thoracic duct via the subclavian vein. Thoracic duct. Now let's talk about one of the pathology associated with the impaired lymphatics is the edema. Edema is the accumulation of the excess of the fluid within the interstitial space. Edema is of two types. We describe it. Either it is pitting edema or the non-pitting edema. Pitting edema is the most common one, which you must have seen during your clinical postings. Pitting edema is that when you will, why it is called pitting? Pitting means like when you will press the affected area, the swelling or the edema, when you will press it, that will result in a visual indentation. There will be indentation formed where you pressed it. And that indentation will persist for some time after the digit is removed. So when you remove the digits, you can see there is a depression or there is an indentation there. And the important thing is when you give the diuretic therapy, diuretics, these are responsible for removing, these are the drugs, diuretics. These are the drugs that is helpful for removal of the fluid via the kidney. It will remove the excess fluids via kidney. So this edema is the excess of the fluid, so diuretics will be helpful. In the non-pitting edema, this indentation, when you press it, there will be no indentation. And the most common cause, it is associated with the increased oncotic pressure. Whenever there is an increased oncotic pressure, whenever there is increased oncotic pressure within your interstitium, for example, proteins, they are increased, then there is non-pitting edema, and non-pitting edema does not respond well to the diuretic therapy. Okay. So let's talk about the edema. So whenever there is we talked about Starling forces. So Starling force is responsible for the filtration and the absorption. Whenever there is a disruption in these forces, this balance of forces, so that there will be more filtration. So there will be more filtration, or there will be increased permeability of the capillary wall, or there is a disruption of the lymphatic system, that is removing excess of the fluid. All of them they can cause the edema formation because of the excess fluid in the interstitium. So let's talk about the increased capillary hydrostatic pressure. Increased hydrostatic increased hydrostatic pressure associated with the increased blood flow, okay, or the increased venous pressure. For example, if there is a venous obstruction or there is heart failure, or whenever there is an increased blood volume, usually in the heart failure. In the heart failure, there is sodium retention causing the increased blood volume. If there is a venous obstruction, that can also increase the hydrostatic pressure. Because of the obstruction, there will be more and more fluid proximal to the obstruction. The fluid will be connected. In the heart failure also, there is more blood present within the in the capillaries, that will increase the hydrostatic pressure. And all of these forces that can result in the formation of the edema. If there is an increased interstitial oncotic pressure, most commonly it is caused by the thyroid dysfunction, because there will be increased mucopolysaccharide in the interstitium that will increase the oncotic pressure. But it can also be result of the lymphedema. Whenever there is a lymphatic system disruption, that can also result in, because there will be, if there is a lymphatic system abnormality or the disruption, that can cause the less removal of the fluid as well as the proteins from the lymph interstitium area, and that can cause the increased filtration. And these increased proteins here, they can result in the fluid accumulation, ultimately the non-pitting edema. Now let's talk about the other factors. We have, if there is a decreased vascular oncotic pressure, that will be responsible for the absorption. If it is decreased, means again there is more filtration. So when there is decreased vascular oncotic pressure, like the liver failure, in the liver failure you cannot synthesize the proteins. In the nephrotic syndrome, there is more loss of the proteins in the urine. So all of them, they cause the decreased plasma proteins. So there will be decreased oncotic pressure of the plasma or the vascular. That will also cause the net filtration. Now, if there is an increased capillary permeability is seen with the lots of agents like various cytokines, like the tumor necrosis factor alpha, with the bradykinin, with the histamine, with the cytokines related to brain trauma, patient in burn patient, they also have the increased capillary permeability, and all of them, they can cause an increased filtration or increased capillary permeability resulting in the edema. Last is the most important, that is the lymphatic obstruction or the lymphatic removal. It can result ultimately. And what are the different causes of lymphatic obstruction or the removal? We have the Buchyria bancrofti infection that can result in the filariasis, also known as the elephantiasis, that can result in the obstruction of your lymphatics. The lymphatic cannot remove the excess of the fluid or the proteins from the interstitium. Then if there is a bacterial lymphangitis, that is a bacteria will involve your lymphatics, cause it to cause the infection of the lymphatics and ultimately impair its function, like the streptococci, also associated with the trauma, surgery, and tumor. So lymphedema ultimately will result in a non-pitting type of the edema, because there is an increase in the oncotic pressure of the interstitial fluid. Now let's talk about the pulmonary edema. What is pulmonary edema? Pulmonary edema is just the excess of the fluid accumulation within the interstitium of your lung. Pulmonary means lung. Now we know the main function of the lung is the exchange of the gas across the alveoli and the blood capillaries. So if there is, like, this is the blood capillary, this is the alveoli here. In between them, there is interstitium. If there is excess of the fluid within this interstitium, it will impair or the interfere with this gas exchange between the capillary and the alveoli. Thus, it can result in the hypoxemia as well as the hypercapnia. Hypercapnia means there will be increased carbon dioxide. Hypoxia means there will be decreased oxygen. So it will impair the actual function of your lung. So let's talk about what is cardiogenic and non-cardiogenic type of the pulmonary edema. Okay. So as we know, just like the other type of the edema, whenever there is an increased hydrostatic pressure and there is an increased capillary permeability, both of them, they can result in the pulmonary edema. Let's talk about the cardiogenic edema. Cardiogenic edema is most commonly due to the increased hydrostatic pressure within your vessels or within your capillary. So whenever you have the increased left atrial pressure, increased venous pressure, all of them, they can increase the capillary pressure and causes the increased filtration. So initially what happens, there is increased lymphatic flow in this response that will be responsible for removal of the interstitial proteins, and that is protective. And the patients with the cardiogenic edema, that will be because it's due to the heart, due to the increased refractive pressure, increased venous pressure, and that's why it's known as the cardiogenic. The first sign will be the orthopnea, that is patient whenever they lie supine or whenever they lay down, they will have the dyspnea or difficulty breathing. And when the patient sits up, he will feel all right. There will be elevated pulmonary wedge pressure. And treatment, you have to reduce the pressure of your left atrium by the diuretic therapy, because that will remove the excess of the fluid from your body. Non-cardiogenic pulmonary edema is due to the increased capillary permeability, not due to the excess of the fluid or increased hydrostatic pressure. And it's most commonly associated with the adult respiratory distress syndrome. The third one is due to if there's a direct alveolar epithelial injury or there's a direct injury to the capillary endothelium. So patient can present with the different symptoms like this dyspnea, okay, which is rapid in onset. There will be hypoxemia. You can find the infiltrates within your lung, and ultimately it can lead to the respiratory failure. And the common causes are the sepsis, bacterial pneumonia, trauma, or the gastric aspiration. All of these conditions can result in the ARDS. That is the adult respiratory distress syndrome. The patients who have sepsis, like they develop the pneumonia, trauma, or the gastric, they're at increased risk of ARDS. And this ARDS will result in the non-cardiogenic pulmonary edema that can present with the dyspnea, hypoxemia, and pulmonary infiltrates. Okay. So what happens? Because of excess of the fluid in the alveoli, it will actually reduce the compliance of the lung. So lung cannot expand. Expansion of the lung is decreased, so there will be difficulty breathing. Here, the pulmonary capillary wedge pressure is normal or low. That is the non-cardiogenic pulmonary edema. This is just a small overview about the pulmonary edema. Now let's talk about how do you measure the volumes of the different compartment of the body. So if you want to measure the volume of a particular compartment of your body, you need a tracer, a substance, okay? That which you give, it will get distributed in that entire compartment, okay? And it is not either metabolized or removed from the particular compartment. And it is easy to measure the amount of the substance that will be spreaded or that will be distributed in that compartment. So first you need a substance that is easy to measure, it will be distributed equally, and it is not rapidly removed from that compartment. And for that you have to use the relationship, that is the volume is equal to amount of the tracer as well as the concentration of the tracer that will be present in that particular compartment. So for example, you use a tracer that is a dye and you gave it intravenously, okay? And the concentration of the dye in the blood is 0.05. So the volume that will be contained within the within the compartment will be 300. That is the amount which you gave divided by what is concentration 0.05. It will be 6,000 milliliter. And this is known as the volume of distribution. So let's talk about what are the different types of the properties of this tracer and the compartment measured. So what happens is that you usually give the tracer into your vascular compartment, and then this tracer will go and distribute throughout your body until it will reach a barrier or a membrane which it cannot penetrate. Okay, and there are two types of the membranes that it will face. First, if it goes into the blood, there will be capillary membrane, and second, there will be cell membrane. So now we have different types of the tracer. We'll talk about it and different properties. We have the plasma. If you want to measure the volume of distribution within the plasma, So you need a tracer that will be not permeable to the capillary membrane. That tracer should remain within the vessel, so that it will be well distributed within the vessel or within the capillary and measure the volume of distribution within the vessels. And one of this is the albumin, because we know albumin cannot cross the capillary membrane. Then they have the extracellular fluid. In the ECF, you will you will require a tracer that will be permeable to the capillary membrane, but not to the cell membrane. Like when you give it in the vessel, it can go out in the interstitium or there, but it cannot enter to any cell. And the examples are the inulin, mannitol, sodium, or sucrose. Now, if you want to measure the total body water compartment, so you need something that will be permeable to both capillary and cell membrane. And the example include the urea and the titrated water. Now let's talk about the blood volume. So what is blood volume? Blood volume is the volume of the plasma. So blood is equal to plasma plus what are the cells in it, like the RBCs. Okay. And this blood volume is expressed in the form of hematocrit. Now let's talk about, to calculate the blood volume is equal to plasma volume upon 1 minus hematocrit. You have to remember this formula, important. For example, if the hematocrit is 50% and the plasma volume is 3 liter, then the blood volume will be 6 liter. 3 liter divided by 1 minus 0.5, that is 6 liter. Okay. So here you need to know the distribution of the IV administered fluid is as follow. We talked about in the vascular compartment, you have the whole blood, plasma, and the dextrin. ECF, you have the saline and the mannitol. And for the total body water, you can give that 5% dextrose in water. So this is the volume of distribution. God. Now let's talk about the ionic equilibrium and the resting membrane potential. So you have to know that there are different electrolytes that are present inside your cell as well as the outside of your cell, right? And these anions or the electrolytes like the sodium, like the potassium, like the calcium, we have magnesium even, we have proteins, they have negative charge. So all of these are either positive, like chloride, bicarbonate, these are either positively or the negatively charged. And these charged particles will result in the these are distribution across the inside the cell and outside the cell. So these are responsible for creating a potential, different types of the potential or the potential difference, like due to the charge outside and inside of the cells, it results in the generation of the potential difference. Okay. Now let's talk about here we have to talk different types of the potentials, and initially we'll give an overview, then we can talk about it more. So first let's talk about what is membrane potential, also known as the EM. Okay. Membrane potential is nothing. It is just the separation of the charge across any membrane at rest. So if we have a cell, here for example we have sodium, outside also we have sodium, chloride. So this separation of the charge, the difference of the charge across this membrane, inside and outside, at rest is known as the membrane potential. Okay. This separation of the charge means there is a potential to do the work, and you measure it in the volts, just like the potential difference. In your high school, you must have heard about it. You measure it in the volts. Then we have the electrochemical gradient. Electrochemical gradient, it is the combination of two forces. First, it is the ion that will diffuse based on their concentration across a membrane. Like ions will always move from high concentration to low concentration, as well as there will be electrical gradient. So it depends upon the concentration of the ions as well as their charge. Like for example, we have opposite charges will attract, same will repel. Okay. Opposite charges will attract and the same will repel. So this is the electrochemical gradient. So electrochemical gradient is determined by the two forces. First is the concentration and the electrical, that is the charge. Then after the membrane potential, we have the equilibrium potential. What is equilibrium potential? Equilibrium potential is the membrane potential. It is just the membrane potential, but in the electrochemical equilibrium. Means it is the membrane potential when there is no net diffusion of the charge. Like the charge here is equal, outside is equal. There will be no diffusion in and out of the charge. So that will be an equilibrium state. At that time, the membrane potential is known as the equilibrium potential. So if if the equilibrium potential is reached, it means if an ion would like to diffuse in one direction, okay, based on its chemical gradient, that will be encountered or countered by the electrical forces in the opposite direction. So that, for example, if the ion based on its chemical gradient or the concentration wants to diffuse from inside to outside, but at the equilibrium potential, what happens? This force is opposed by the electrical forces that will be in the opposite direction and equal and will cancel this force. So there will be net no diffusion of the particle. This is known as the equilibrium potential. And to calculate the equilibrium potential, you have an equation that is known as the Nernst equation. We'll talk about it. Then we have the conduction. What is conduction? Conduction is just the flow of the charge across any membrane. Okay. And you know, this charge or the ions, they will move across the membrane via the channels. And you have to know there are both open and the closed states of the channel, as well as these states determine whether the membrane is permeable to these ions or not, as well as the conductance. We know whenever the channels they are open, there will be more conductance, more permeability, more conduction. When they are in closed states, there will be no conductance or low conductance, right? And then we have the net force. Net force is just the force that will determine the diffusion of an ion, whether it will move out or inside of the cell. Okay, that is the net force. Now here you can see different types of the ions inside and outside of the cell. You have to remember, outside the potassium is always high, outside the calcium is high, outside the chloride is high. Only the potassium is low outside. You have to remember. And the opposite is true for the inside. Inside everything is low except potassium. So cell inside is high in potassium, others are low, and the outside or the interstitium is high in others but low in potassium. You have to remember this here from this. Now let's talk about the different types of the ion channels. So as I said earlier, if these ions will like to move across this membrane, they require the presence of these channels that will cause the diffusion of the ion across these membranes. So we have three types of the channels. First, we have the ungated or the leak channels. They are called leak because they are always open. Okay. And the direction of the ion depend upon its electrochemical forces. Same. Then we have the voltage gated ion channels. Voltage gated ion channels, they have either the open or the closed state. They are not always open, both, or they can be open or they can be closed, and that is determined by their membrane potential. Okay, what is the potential? That will determine whether it's open state or is in closed state. Okay, if there is a change in the membrane potential, that can open or close the channel. Then we have the ligand gated. Here there is a ligand or a receptor. So what? No, sorry. So there is a ligand and there is a receptor on the channel. So what happens when the ligand binds to the receptor? That will cause the change in the ion channel. So that channel will open or close depending upon the ligand. Most of the cases, whenever the ligand bind to the receptor, it will open the channel, but not always. There can be sometimes, mostly it will open, but it can be it can close also, right? So as you can see, this is the ungated or the leak channels. These are always open, like the potassium is moving from inside to the outside by this ungated or the leak channels. Then we have the voltage gated. Here the open or closed state depend upon the voltage or the membrane potential. Then we have the ligand gated. This is the receptor. The ligand will bind here. It will cause a conformation change that will be responsible for opening or closing of these channels. Now, there is one exception in these three classes of these channels. We have the receptor for NMDA, that is the N-ethyl D-aspartic acid. They are both voltage gated as well as the ligand gated. So what happens is that, let's talk about here. Usually the opening or the pore of the NMDA receptor is blocked by the magnesium. You can see it is blocked. This is the opening, it is blocked by the magnesium. So whenever the membrane potential, it becomes more negative than minus 17. So minus 70 is like the resting membrane potential. That is at the rest. So whenever it becomes less negative, sorry, more negative than minus 70, okay, the magnesium one, at that state, the magnesium is blocking these receptor and there will be no movement of the ions. Whenever it becomes less negative, the magnesium will be removed and it will lead to the unlocking of the channel. Okay. So thus it depends upon the voltage. That's why we called it a voltage gated channel. You got it? So magnesium is just like a gatekeeper. Whenever it is more negative than minus 70, it is in the closed state because magnesium is blocking it. Whenever it is less than like when it's less negative than minus 70, then it is an open state because then the magnesium is removed and thus it can move. Thus the ions can move across this channel. Second, it also have properties of the ligand gated. So the ligands here are the glutamate and aspartates. Whenever these aspartate glutamate bind to these receptors, here this is receptor ligand site, it will lead to the opening of the channel and the movement of the ions. So this is the ligand gated properties as well as the voltage gated properties. So let's talk about it. If the membrane potential is more negative than minus 70, right? If it's more negative, what does it mean? It means the magnesium will be blocking it. So already the channel is being blocked by the magnesium. So this is the channel. This is already the magnesium that is blocking it. So even if the ligand will bind to the channel, there is no opening of the channel because the magnesium is still there. It's blocking the channel. But if it is less than negative minus 70, the magnesium is already removed. Okay, it's an open state. So even if with the ligand binding, so if the ligand will bind to it, there will be no opening of the channel because the channel is already open, right? Because there is no magnesium. So this is the interplay that there is two properties that will be determined by the membrane potential as well as the presence of a ligand, that is the glutamate or aspartate. You have to know NMDA receptor, it is a cation channel. It will be responsible for the sodium, potassium, and the calcium flux through it. So thus, wherever there's an opening of the channel, so this is the channel, the calcium, potassium, and the magnesium will go inside and it will cause the depolarization. And you have to know that the function of the NMDA receptor is mainly in the CNS. It is present mainly in the CNS and responsible for the memory and the transmission. Okay. Then let's talk about the equilibrium potential. As I said earlier, equilibrium potential is the potential difference that will put an electrochemical that will put an ion in the electrochemical equilibrium so that the ion cannot diffuse across the membrane. It will be stationary. It cannot move across the membrane. So there is no net diffusion of the membrane, as I said earlier. So to calculate it, we use the Nernst equation. You don't have to remember the exact equation. Not always. So equilibrium potential is equal to 60 upon Z. That's the value of the charge into log 10 of x0. That is the concentration of outside. What is the concentration of the ion outside? And what is the concentration of divided by what is the concentration of the ion inside? So you don't have to remember this equation. There are important points you have to remember. The ion always diffuses in a direction so that it can bring the cell towards an equilibrium potential. So that, of course, we know that ion always moves from the high concentration, right? From a low concentration. Why? Because it wants to equilibrate the concentration on both of the sides. And that equilibrated concentration will cause no diffusion. That will be an equilibrium state. So always the ions diffuse in a direction that will want it to bring towards the equilibrium state. That's the equilibrium potential. You have to know the conductance of any ion is dependent upon the net force. as well as the permeability. Permeability is also very important for that ion. Also, the number of the ions that actually moves across the membrane is negligible. So opening of an ion channel does not alter the intracellular or the extracellular concentration of the ion under the normal circumstances. Okay. So let's talk about, you have to remember all these equilibrium potential for the different ions, right? So these unique things you need to remember. For the potassium, it's 95, minus 95. Sodium, it's plus 70. Chloride is minus 76. And the calcium is plus 125. In the deep, whenever there is depolarization, you have to know that the membrane potential always becomes less negative, that it will always try to move towards the zero. Okay. So if, for example, inside of the cell is negative, depolarization, there is more sodium going into the cell. So it will try to become less negative, that is more towards the zero. In the hyperpolarization, the membrane potential will turn to become more negative, that is further away from the zero. So that is the depolarization and the hyperpolarization. Now let's talk about the resting membrane potential. You have to remember that the resting membrane potential for all the nerves is minus 70, very important. And for the striated muscle, it is minus 90. So this thing you have to remember. For the nerves, it's minus 70, and for the striated muscle, it is minus 90. Okay. You have to know that in the normal tissues, we have or in the excitable tissues, you have lots number of the leak channels for the potassium, because we know inside of the cell always has the high potential and outside is low. So there are always these leak channels present in the cell wall that will cause the constant flow of the potassium from inside to the outside. So you have to know that the conductance of the potassium, even in the resting cell, when there is no movement of any other ion, is high because of these leak channels. So you have to know the concentration of the potassium outside the cell, right? The potassium is moving inside to outside. Why? Why? Because in the inside, as I said earlier, inside the cell, the potassium is high and the outside is low. So wherever there is an alteration of the potassium concentration outside of the cell in the extracellular space, that will always alter this potassium flow, this high conduction of the potassium at rest. So what happens? In the hyperkalemia, hyperkalemia means there will be excess of the potassium outside. Outside the cell, there will be high number of the potassium. This is the hyperkalemia. So outside potassium will increase. Hyperkalemia will actually cause the leak channels will cause the excess of the potassium to move now inside the cell, not outside. Okay. Now, as it moves outside, the charge inside the cell will become less negative because the positive charge is moving in. So it went into hyperpolarization. Sorry, what I'm saying, depolarizing. It becomes less negative. It means it is depolarizing. Okay, and that can increase the risk excitability of the tissue and can result in the heart arrhythmia. Hypokalemia further will cause the movement of the charge outside of the cell. Hypokalemia means decreased potassium. It will cause the potassium to move further outside because already excess inside from the high concentration to the low concentration. The positive charge will decrease. The charge will become more negative than minus 70. It means there is hyperpolarization. So that will also increases the risk of arrhythmia. So whenever there is hyperkalemia or hypokalemia, any alteration of the potassium concentration in your body is associated with the increased risk of heart arrhythmias or the heart disease. So as I said earlier, if there is increased conduction of the potassium, will cause the potassium to move out, resulting in the more negative inside of the cell, causing the hyperpolarization. Okay. And you have to know always that the ion will try to move towards the equilibrium potential. Thus, it will become more negative from minus 70 to minus 95 because minus 95 is the equilibrium potential for this. Minus 95 is the equilibrium potential. Minus 70 is the resting membrane potential. So if there is decreased conductance, means there will be less negative because less of the potassium will be moving out. So there will be depolarization of the cell. because we know the potassium conductance is high at the resting state because of the presence of leak channels. So that is the potential for the potassium. Now let's talk about a very important pump that is present in your body. That is the sodium potassium ATPase pump. So first, you know that our cell membrane, all the membranes in your body, they are usually impermeable to the potassium, but it's not completely impervious, like because of the presence of these channels. These are known as the sodium potassium ATPase pump. So although our cell wall, it is impermeable to the potassium, to the sodium, but some of the sodium still leaks inside the cell, right? Some of the potassium still leaks inside the cell, and to counteract that leak, we have a a pump present here that is known as a sodium potassium ATPase pump. This is the pump. This potassium will move the sodium out and will pump the potassium in. And this cell is actually responsible for keeping the high intracellular concentration. What I said you earlier, there is a high potassium inside the cell and low sodium. And sodium potassium ATPase pump is one of the pump that is responsible because it keeps pushing potassium in and the sodium out. So there is high potassium inside the cell and low potassium outside the cell, or high sodium outside the cell. Okay. And you have to remember, this is not a ballast pump. What it does, it moves 3 potassium sodium out in exchange of 2 potassium in, so that there will be net negativity inside of the cell. That's why we call it 70 millivolt is the resting membrane potential. So there is net negativity because of this imbalance, because there is 3 sodium out and 2 potassium in. Okay. Because more positive charge are moving out of the cells, so there is a negative charge inside the cell, as I said, I told you. Okay. So also, because 3 sodium are moving out and 2 potassium are moving in, more solute are moving out. So there will be solute is moving out, it will be carrying water with it. So there will be more water moving outside of the cell. Okay. So this is the sodium potassium ATPase pump. Let's talk about the chloride. How is the conductance of the chloride? So you have to know, again, at the resting state, chloride has a very low conductance. So that's why if you decrease the conductance, or you will change the extracellular concentration of the chloride, it will have the minimal effect on the resting membrane potential, because already the chloride, the conductance is very low, so it will not have much. Okay. So let's talk about, if the resting membrane potential is minus 70, if you will increase the chloride, it will hyperpolarize the cell, right? How? Because if you will chloride, if you'll increase the concentration of the chloride, it will make it more negative, the resting membrane potential, from, for example, minus 70 towards the minus 76. So it means it will hyperpolarize. And if you'll decrease it, it will depolarize it, because there will be less negative charge. Same thing. Again, sodium chloride is not very important, ion responsible for the resting membrane potential. Sodium, we know its conductance is also low at the rest. So if you'll decrease the conductance of the potassium, or if you're changing the extracellular concentration of the potassium, it will have no effect on the resting membrane potential. But if you'll increase the conduction, so if you'll increase the conduction of the potassium, right, sodium, sorry, if you change the conduction of the potassium sodium, so now the sodium will be moving, because inside the potassium, sodium is now low, the outside will be high. So now the sodium will be moving inside the cell, right? So the inside becomes less negative, so it will cause the depolarization. So if you increase the conductance of the sodium, that will actually depolarizes the cell. It will make the charge inside the cell less negative. So you can see sodium. If you'll increase the sodium conductance across the cell, outside we have more sodium, right? Inside we have less sodium because of this sodium potassium ATPase pump. So this more sodium, because and we know the ions or the sodium will move from the high concentration to the low concentration. It will move from outside to inside, and it will decrease this minus charge. So it will become depolarization. The charge will become more positive. If you increase the conduction of the sodium, again, chloride is less inside and outside there's more chloride. So if we increase the conductance, the chloride will move in. That will cause the hyperpolarization. It will make it more negative because more negative charge is coming in. Let's talk about calcium. The conductance of the calcium again is very low at rest. Unlike the potassium, all of the other ions, they have low conductance. If you will decrease the conductance of the calcium, or if you change the extracellular concentration of the calcium, it will have no effect, of course, because there's low conductance, right? Already there is low conductance. You further low it or you change the concentration, it doesn't matter because there is no channels available. It has a very low conductance. But if you increase the conductance of the calcium, also calcium is high outside, similar to the sodium. So it will move inside the cell. It will decrease the, it will make it less negative, the resting membrane potential. So it will depolarize the cell, move it like around 125. Okay, so that is the information regarding the conductance of the different ions. So you have to remember sodium potassium ATPase pump, what it causes, it moves 3 sodium out and 2 potassium in. So that's why there is a, because more positive charge is moving out, net negative charge inside the cell. That's why we see the resting membrane potential is like -70 of the nerves. Okay, then what do we have? We have like inside we have more potassium and we have outside less potassium. There's a leak channel of the potassium available even at the rest. Then we have the sodium. Increasing the sodium conductance will depolarize the cell. If we increase the conductance of the sodium, if we increase the conductance of the calcium, that will also depolarize the cell because both of them can move inside the cell and will make it less negative. If we increase the conductance of the chloride, more chloride will move in and cause the hyperpolarization, not the depolarization, making it more negative, the resting membrane potential. So that is the thing which you need to remember from all of this stuff. So we'll stop here and then we'll be talking about the action potential and the synaptic transmission in our next